You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
And welcome back to Clinical Rounds for part 2 of our time with Stuart McGill. Stuart, thanks for joining us again today. Can't wait to hear some additional clinical pearls from you for this second part of our interview.
Thanks so much, Bill. It's been wonderful to catch up with you.
Now, you talk often about the lost art of the assessment and how you've seen modern clinicians. I think one of the thing is with these abbreviated visits, people rely more on taking the pictures rather than assessing the patient. And I totally agree with you. That piece of paper is just a pale attempt to try to show a three-dimensional structure on the MRI or X-ray. So learning to read MRIs, learning to read X-rays, I think is part of what every clinician should do. But the assessment is what brings it all together. And you do the assessment before you look at the images, I believe, too.
Yeah, absolutely. And I've tried to understand why clinicians today have lost the art of the assessment. Because, when you and I were, let's go back 30 and 40 years and you think of some of the great leaders in chiro and physical therapy and et cetera. And, I think of Jeff Maitland, and it was you listen to the patient's story. You form a hypothesis. Your assessment are testing the hypotheses from the pattern recognition of the interview. And somehow all of this got lost through the technology. Oh, well, let's take a picture and that's going to be our assessment. And as we've already pointed out, that picture at the right time for the right patient is invaluable. Or it's the opposite. It's really cumbersome for them. So I think that's why clinicians have lost the assessment. And I might also say that if we go to a higher political type of discussion, clinicians perform, what should we call them here? Interventions or things that are billable codes by an insurance company. How many codes are there that incorporate a thorough assessment? I think there are 0. So a clinician isn't even incentivized to perform a thorough assessment. And
but they are incentivized to do procedures.
Of course, they are trained to do a procedure. Well, if the procedure matches the mechanism, that's dumb luck. I don't want to work on dumb luck. I'm not a casino player. I only go on where the assessment takes us.
So you're a scientist and understands the nuances of all the studies you perform, but what advice would you give to us mere clinicians who like to conceptualize what's found in the research? Because you've seen people, they grab a research article of yours possibly, they interpret it this way, and you're like, no, you got it all wrong. The nuances show this. This is really what we're uncovering here. How can we best interpret the use of research and apply it to our practices?
Right. I think what you're talking about is incorporated in this term that I use, the master of the craft. So it takes a person a lifetime to become a master of the craft. And I don't even know if I'm ever going to get there either. But my point is we keep on trying to reach this level of mastery. Well, when I was younger, I looked after the science end because that was my world. But I sought out great clinicians. I sought out you for your thoughts on image interpretation. I would go and speak with Harry Farfan, Kirkcaldy Willis, Lance Toomey in Australia, Shirley Sarman. Do you remember Dick Earhart from Pittsburgh? Dick and Tony DeLito and whatnot. Dick was a chiro and a PT, and I would seek these people out to really understand. Now, I could read their papers, but when you talk to the person, all of a sudden they give you gold. And it's a real problem with the stresses on people who publish, you can have 6 pages in the journal, and you have to pass statistical rigor, which means you have to propose a hypothesis, test the hypothesis. It's the most boring stuff to read. I'm going to tell you something that will surprise you. I have never formed a hypothesis for research in my life. I have made them up after I've done the science. So every experiment that we did, it was a fishing trip to go and see what happened. There was no hypothesis. I just wanted to see how the spine would behave, or what would modulate the pain, or what this test showed us in terms of signal content, etc. Then afterwards, in order to get it published, the very rigorous publishers would say, well, what's your hypothesis? Well, truth be known, I don't have one, but here, I'm going to make one up so now you can publish it. Now, all the commentary is rallied around that one hypothesis, but we learned 10 new findings and we disproved 2 others. But you can never mention that in the paper that's published. So there's a real problem. And the other thing is, there's these artificial impediments to enhancing the science of discovering the patient's pathway, or let's just call it assessment. The journal says, in order to publish a new test, you have to show its repeatability and its reliability. I couldn't care less if a test was reliable. I do care if it's specific. So what do I mean by that? If a junior first-year student performs the test and gets exactly the same result as you, a master of the craft, it means it's a very simple test. It's repeatable, it gets published, but it is not specific. The slump test, you and the first-year student are going to get the same result on the slump test. The slump test missed the Tarlov cyst. It was highly non-specific. But when we play jazz as a master, start out doing the slump test, it's not replicating the symptom. Straighten the knee, tilt the head back, and there's your symptom. That would fox a first-year student, but you would get it because you know your neurodynamics and all the rest of it. So my point in that, Bill, is I care about specific tests. By definition, they are complicated. They require expertise. They are not repeatable, and therefore they're not allowed in the publishable literature. So they never make it.
Wow. So that's heavy, but it also talks about, you say, about mastery, understanding the spine, understanding how the body works, that when you extend your great toe, how that's going to tug on there, and how much pressure that's going to put, and something was tethered in there. And then you just have to find out, where's the tether? Can I find it? That's a great example. So what is your foundational approach to pain-free activity? So you take people that come in pain, and you say, okay, like the patient you said before, you've lost some disc height, you had instability, it's going to degenerate, you'll get more stability, but in the meantime, how do you get that person from from a painful lifestyle to a pain-free activity, or being able to live a normal life?
Well, there's 2 stages to that. The first stage is to know enough about their pain pathway. Can you create a strategy to desensitize their pain and create a repertoire of normal activity that doesn't trigger their pain? So, for example, can they tie their shoes now for the first time in months without triggering pain? And you might find this interesting. I've got 3 players in the NHL, the National Hockey League right now, who don't tie their own skates. A trainer ties it for them because they have discogenic, open fissured disc bulges, which is very common among hockey players in the NHL. And part of their management strategy is, well, if they did tie their skates, it would set them up and they just might have an acute attack during the game. But they've learned that if they don't do that and they sit tall on the bench, that disc remains robust for the rigors of hockey. It's really quite remarkable. So that's stage 1, giving the person a strategy to stop picking the scab, so to speak, and allow the desensitization to occur so that they can dress themselves, go for walks, feed their dog, put on their shoes, go to the toilet, etc., with no chance of pain. Now, the next stage is getting them back to life. And a little bit of a subspecialty for us is elite athletes. So we've got athletes who we've restored their careers and created, I don't know how many world records in powerlifting have
And you've
been
got an
from
interesting
our
book on this
patients.
too, The Gift of Injury.
Right. So Brian Carroll has now squatted 1,308 pounds, the highest of any human in history. He came to me as a back pain patient who I honestly was wondering whether I could even get him out of pain to start off with, and that was in 2013 or 2012. But in the last 10 years, he's recovered his ability and set the all-time record. So no, you don't tell me that a disc bulge and a fractured vertebra and whatnot gives you lifelong disability. I don't believe it. But right now we've got active athletes in the UFC, the NHL, the NFL, NBA, many Olympians from different sports. And why I'm saying that is every single one of them came to us as a disabled back pained person. So we worked to wind down their pain, figure out how to build a base athleticism of pain-free everyday activity. Then the key is now we switch to I don't want to say integrating exposure, because it's a little bit more than that. We have to prepare their bodies to start training again. We begin by assessing the demands of their sport. What does it take to compete at a high level? Most clinicians will have to take one of our courses to figure that out. That's if you think it's strength, flexibility, it is so much more than that. So we understand the demands that are eventually going to be required. Then we assess their bodies right now. If they have what they're going to need, our job is done. But then we identify what they don't have, but they will need, and we train those things in a balanced way, recognizing that biology has a tipping point. If you run up against the tipping point, eventually you're going to cross it, and you're going to get re-injured, or you're going to backslide on the rehab program. So we have ways of what we call the 3-day rolling cycle to slowly keep stimulating the adaptations that athlete needs, hoping to eventually restore world-class athleticism. Do we always get there? No. Probably fail for world-class athleticism more often than we succeed. But they sure get their life back, and they're playing pickup basketball with their kids in the driveway, and the real important stuff when you get right down to it.
Well,
it's assessing the demands of the sport or the military career, or they want to be a plumber or a police officer, whatever that happens to be, and then conditioning their body, honoring the rules of biology within their current anatomy and their specific response physiologically, etc. N equals 1.
That's the big thing right there. It's always about that patient. It doesn't matter what the bell curve of the study says. If they're in the outlier and that helped them, that helped them. And we adapt our treatment for that person. And if they get better, that's all that matters. It doesn't matter what any other study says. You found the cause for that person and the correction. You also mentioned, and we're getting close to the end of our time here, the general goal that we should be harder to kill. What do you mean by being harder to kill?
I think that's the essence of evolution. The strongest will survive. So we've just been through a pandemic. Hopefully, people were as resistant to that as possible to survive. Hopefully, physical activity doesn't break them down. It makes them stronger. Hopefully, emotional family situations in life, they are robust enough to withstand them, to make them stronger. So it's a very wide concept, and I think it's the job of us all to guide those people who seek our expertise and services to make them harder to kill. So it's a kind of a catch-all objective, I suppose, and it raises eyebrows I'm not talking about gun violence or
Yeah,
anything
I
like
get
that.
it.
I'm just talking about the rigors and challenges of life. We
Well-
all want to be as robust and as able as we possibly can and let loose a little bit, have some fun.
Stu, thanks for joining us today. And Stu, before we go, is there contact information or someplace you'd like to direct our viewers so they can contact you or your company?
Well, I get the audience. They are clinicians. I learned something in the pandemic, Bill. Prior to that, we would go around the world once a month and put on our courses, and I found I don't need to do that anymore. I put my courses online, and I was a bit arrogant, thinking that they would not be as effective as me being in the room on the stage. As it turns out, when a clinician views our courses online, our courses are very dense in terms of information content. And the common kick was always, oh, you go so fast, there's so much material. Well, they can go back online and review the parts that they would like to review. But I can never teach hands-on skills. So what we are doing is delegates will take our courses online, and then they will meet somewhere, and we're currently working on that somewhere in the US, being Parker College. And our chief instructors, Ed Cambridge, who you know is an outstanding clinician, and Joel Proskowitz, come in and teach those hands-on skills. We don't have to waste time with any more of my lectures. It's all day long refining. Can you feel this? What does that mean? Can you modify this? How do you measure whether you modified it, etc.? So that's the format that we're rolling out. And of course, there's our various books as foundational material, and you can see those at our website, backfitpro.com.
Well, thank you very much. And you've been listening to Dr. Stuart McGill.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.